you go away from pain. If you can say, oh, just a little bit of pain, okay, challenge him. Go into that provocative position. If it's too much, go away from pain. So either increasing tension or reducing tension, depending how they feel. Guys, now we're going to just do a case study, really trying to implement all our thinking, clinical reasoning, understanding what, in terms of hypothesis, might be wrong with this patient. So have a look. So we've got a 28-year-old female. She has a 2-year history of headache. Gradual onset since 2022, since she had a glandular fever. Also, at the time, mother has been diagnosed with breast cancer and father with prostate cancer. So there's a lot going on in 2022 for this patient. Works in a law firm 5 days per week. Sits 80% of the time. See, remember when I said I asked the patient, tell me about your daily activity. Percentage-wise, sitting, standing, walking. She says she sits a lot. So there's a lot of sitting, isn't it? 80%. No 5Ds, no 3Ns or A, so no red flags. Dysarthria, dysphagia, diplopia, drop attacks, dizziness, nystagmus, nausea, numbness, or ataxia. So screen, no red flags. No history of trauma to the head and neck. When probably I don't need to do instability test for her, do I? Think about it straight away, because no history of neck pain and no history of trauma to the neck or head. General health, no problem, no nil abnormality detected. Medication, immigrant, minimal effect. Nurofen 10 tablets and 5 aspirin tablets per week takes the edge off. So it's not resolving. Previous treatment, important to ask. Osteochiro, manual therapy, massage with short-term relief only. Stop going. Makes sense. Beliefs, not sure what's going on. Different clinicians say different things, so she's confused. Now, that's her headache. She's got blue and red. Blue are called PA, red PB. PA, 8 out of 10. Pulsatile, quality visual aura, photophobia, phonophobia, nausea, time once per month, last for 2 days, no associated dizziness. PB, intermittent, 4 out of 10, 8, often starts in the neck, then radiates into the head and temple region. Frequency 3 to 4 times per week, better on the weekends. So this is her body chart. Important to know, remember about the headache, frequency, intensity, duration. Always ask. Yeah, very important. Okay, and then aggravating factors. For PA, for red one, starts 4 days before menstrual cycle and aggravated by physical activities such as running or fast-paced walking. Other triggers, alcohol and dairy products. PB, aggravated by 2 hours of sitting in front of a computer, can wake up with a low-grade headache, but usually neck and headache worse as the day progresses. Stress can also affect the headache. And easing factors, PA lying in bed, PB walking. Okay? So don't need to worry about too much about this. Okay, so what I want you to do, draw the table, hypothesis, evidence for, evidence against. Okay? All that what I said about in terms of the history and really the education, aggravating factors, put that all together and come up with a hypothesis. And also in terms of evidence for and evidence against. Okay, so you need that information, yeah? So then you can put that together in a group and then discuss that. What do you think? So try to answer by yourself first, and then discuss that with your peer. Okay. So has this patient got what? What has she got? Maybe someone at the back, guys. What do you think? You guys, your group. What do you think?
I think A should be migraine.
So for PA, it's a migraine, and why do you have this a migraine? Why do you think it's migraine?
Because the pain type is a pulsating pain, and it correlates with the photophobia and photophobia.
And what else?
And then for the medication, the Nurofen Google it on that. Canada is helps with my brain.
But let's go back. What other things? What other things is the pain for PA? Resting. Resting. So physical activity problem could increase the headache. Yeah. So if it's resting, feels better. So don't forget to add that. Okay. Is pulsatile? Is it pulsatile or not?
Yeah.
Yes. Is pulsatile? Yeah. Good. And you basically that's it. So you need only 3 out of 4 to diagnose migraines. That So evidence against, I would say very little or none. So really, a lot of evidence to suggest that this patient got migraine. Okay, and what maybe in particular, what kind of migraine do you think the patient has? Menstrual migraine. It starts 2 days before menstrual cycle. So maybe drop in there, estrogen levels, isn't it? And that can change the balance basically. Yeah? And remember during pregnancy what happens normally? The headache improves so easily. Because estrogen is always good. NPB?
Sorry, just to ask for the pain pattern, does that count a unilateral or bilateral pain?
Remember with the pain patterns, if you looked at the APOL study, not always we can be very specific with the things to tell which type of headache. Usually it's unilateral with the headache, with the migraine, but sometimes can be bilateral. So because especially with the chronic pain, so then the brain spreads, converges, it becomes less predictable. Okay, but for you, for example, I think it's only one side, isn't it? So in this case, it doesn't have a chronic migraine. It's kind of frequent, I would say, but it's not chronic and it doesn't last long. But it's more, yeah. So pain pattern is not always, we can't rely only on pain patterns. Good job, guys. Okay. What about you guys? So what about PB? What do you think is PB? You got any? So what does it mean? Yeah, somatogenetic headache. And based on what? Why do you think it's somatogenetic headache?
Based on that it is side dominant, it's over the right side, and it is from the neck to the head, and it is also non-flowing,
Yeah.
and it's also
And physical activity is not making it worse as well, which is because it in fact helps to do some physical activity. What you do walking, remember pain easing factors as well.
and also there is the marginal effect of the anti-migraine.
The what?
There's a marginal effects of the anti-migraine medicine.
That's right. So that's a good evidence because for cervical headache, because usually the migraine medication wouldn't work. But what could potentially happen is she's taking a lot of medication, isn't it? She may have a rebound headache based on toxicity as well because she's taking a lot of medication, more than 15 tablets per month. So something to consider. But certainly she seems she's got the mechanical component, isn't it? Better on the weekends. She's seeing job, again, postural component potentially. So good. So again, sounds like 2 types of headache, isn't it? And I think you asked me, could it be 2 types of headache? Yes, it can. And you know what's the question to ask? Very, very important question I think to ask. Because sometimes you give you so many symptoms and you get lost. Oh my God, so where do I start? What happens? So you need to control a bit of that environment. So I said, if the people is a bad storytellers, you have to guide them. I said, so then you say, do you always have the same type of headache? That's the question. And if you say no, okay, so tell me about the one headache, frequency, intensity, duration, Okay, now tell me about this one. Or maybe you have a third one. You can have mixed. So do you always have the same type of headache? So you said no, one headache I have before menstrual cycle, and then a headache when I'm stressed. Do you know what I mean? So it's kind of just really helps you again to get a bit more clarity interpreting the subjective examination. Wonderful. So I think guys, really well done. Now, so for migraine, we don't really have much role, isn't it? Apart from probably send it back to the GP and review medication, or maybe the neurologist or whoever is prescribing medication needs to review for the migraine. Lifestyle factors, so we can maybe educate on triggers, alcohol, cheese, because remember triggers. But we don't really do probably manual therapy for migraine, but certainly we can treat some microgene component in the presentation. So we assess, and what do we do? active, combined movements, flexion rotation test, and then looking, okay, is it C01 problem, maybe C12? We're also going to do some muscle function, maybe some motor control issue in the neck that needs to be addressed. So this is how we kind of come to that, a bit of a plan in terms of assessment. So migraine, forget it, but we can assess microgenic components for inspection. Is that helpful, this kind of case study, just to put all things together?
Yes.
All right. So well done, everybody. And you know what I say? Arrivederci until tomorrow. See you tomorrow.